All right, so make sure I'm working here. Hold on, everybody. I just again as a reminder is I record everything on YouTube, so everything during the conference will be recorded and posted on the internet. So yeah, forever. It can be accessed by your grandchildren, your grandmother, your neighbors, and all sorts of different variations. So I like to do interesting cases. This is not the patient, but it's the same BMI as the patient because it gives you an idea of the problems. It's a 41-year-old woman with left sciatica. She had symptoms for 4 months, but she had the same exact thing for years that has been going on and off, on and off, on and off. And the pain's left posterior buttock, left posterior thigh to her left heel, plantar foot. And she's had medications, diclofenac, Paul, nothing's getting better. So plantar foot, what nerve root, is any, like a resident here, what nerve root would you think plantar foot? S1, okay. And she has diabetes, high blood pressure. She's a cigarette smoker, half pack a day for 22 years. And her BMI is 53. She's 5'1". So S1 is a pretty good bet. Maybe L5, maybe S2. And 53, what's BMI 53? Is that high? So you can see the distribution. The highest, I guess 25 is the median, sort of. And this is characterized as super obese. And what implications is it? The complication rate is at least 2 or 3 times. I think for super obese it's 4 times. So every single complication that you have normally is magnified dramatically. And can anybody tell me, any residents or anybody tell me any ideas? I just put some ideas, just time, depth of the wound, this difficulty working in a deep wound, stress on the implant. And also, I think as a surgeon, limited focus. So you only have so much time that you can really focus. You can't focus for 12 hours. Anybody add anything to that, like obesity issues?
Yeah, there's different types of obesity. There's male body habitus and female body habitus. One thing that's important to determine is that you can have a person who looks like severely obese and all their weight is in the belly, like a guy normally gets, and their spine is actually pretty close. So there was some studies showing that the distance, you can actually measure the subcutaneous fat, and it's more than 5 centimeters. That's what really increases your chance of infection. So just because you have a number, it doesn't correlate necessarily with the body habitus and what you're going to see surgically. So that's an important consideration. You can feel the spinal processes in a really obese patient no different than a person who's thin as far as actually your surgical procedure.
So yeah, so if you're a round person, a lot of fat at the surgical site.
Right. If you have a typical Kardashian look, that's different than the person who's got the beer belly.
Yeah. And actually, some women have a lot of fat that are not obese, just happen to have a lot of fat right where your surgery is.
Right. Exactly.
I've had that happen too.
That's a consideration when
you
see in the MRI, I think.
Yeah. Okay. So here's an oblique fracture. This is an oblique view from 2016. So who can tell me what's at the arrow? Anybody? Megan? It's a pars fracture, right? And it's also called the Scotty dog, where the collar is on the Scotty dog on the oblique view. Now this is 2016. Who wants to comment on the lateral view? Anybody? Megan? You know everything. Yeah, you do.
It looks like there may be a pars fracture as well, but then you also have some spondylolisthesis or L5 on S1.
In 2016. So, yeah, and Dr. Samir, what number classification would you give this?
Usually you go by 25% increments.
Yeah.
So I would say probably this is grade 1.
The grade 1?
Yeah.
Okay. And is that at L4, L5, L5S1? This is like, I don't know what to call this because is it L4, L5? Is it L5S1? What should we do? Should we just do what the radiologist says just to keep it? Because if there's a discrepancy in the level, it's a big deal, and everyone's confused.
Should I answer?
Yeah.
I mean, I would try to get whole spine imaging.
Yeah.
And count from C2 and down.
Yeah.
And see what I end up with.
Do you do that for every MRI?
Well, we have scout imaging on MRI.
Every MRI?
Yes, that will allow us to see the whole spine.
So you go from C2 and count down?
Yes.
So C2 to 7, 1 to 12, and then down?
Yeah. I mean, you may have, so in this case, you could have an S1 that looks like a lumbar spine, or you can have an L5 that looks more like S1. So it depends on the numbering, and so that's what I usually do.
Okay.
And then if I'm not,
Yeah.
And if I'm not sure, I don't have the whole spine, then I tell you exactly how I numbered it.
Okay.
So I would tell you in the report that I
Put that in
counted.
your report.
Yeah, that I counted from the bottom up, and this is the level. And if I have if it's a CT, for example, I'll give you like an axial image number.
Yeah.
So you and I are both looking at the same number.
Yeah, what were you gonna say, Justin?
I was gonna say, I just try to describe it, and I think the key is making sure you're operating at the right level.
Right.
And if you describe it and you keep it in your notes, and then you say, this is what I'm numbering at, then you're consistent in your office notes and consistent in your out note. To me, that's, like, I would describe this as sort of the first open disc, above the sacral segment.
That's what I say. I say I'm gonna call the last square vertebra blank.
Yeah, you could call it S4 and S3 if you wanted. You just gotta make sure that what you're calling it stays consistent.
Yeah, okay. So, the pelvic,
I
yeah,
was to say there might have been like an element of dysplasia on that because you see some rounding of S1, a little bit of sort of a trapezoidal appearance to L5, or whatever if you call it L5.
Yeah, that really wouldn't be, and I don't know if Spiro has other, dysplastic L5S1 is way more dysplastic.
yeah, we're gonna get into that.
Dysplastic.
We're gonna get into that.
You also see where the top of the crest is, so that probably is physiologically L5S1, the top of the crest intersects at 4 or 5.
Okay, so, again, this is 2016. Pelvic incidence is 57 degrees, which is pretty much normal in this patient. And why is that important? The larger the pelvic incidence, the sacrum has a more of a downward angle, gives it a higher probability that the slip will progress. So here we are, 2018. Now, I didn't see her in 2016. I saw her in 2018. So what do you guys think? Got worse, better, same? Just a standing view? Any comments? Well, I mean, I thought maybe it got a little worse. I didn't like the look of it, and I thought it was getting worse in this patient. And flexion extension views did show some motion. For me, that's a worst case, because if it was fused, it wasn't moving. I mean, it doesn't matter. I was going to fix it anyway. So, Dr. Samir, what do you think of the MRI findings here?
So basically, MRI, it demonstrates what we're seeing on the radiographs. It's more of a grade 2 spondylolisthesis right now on the MRI. And it's showing that the canal is quite capacious at that level. But the question is, what is it doing to the neural foramen? So there's significant narrowing of the neural foramen because of the one vertebral body sliding over the other. So I would be concerned about exiting L5 nerve roots impingement or encroachment. And then the other thing we're seeing is element of degenerative changes involving the facet joints.
Yep.
So
Agreed. So this here, I just want to show everything. The axial. If you guys want to comment and stop, I'm just going to kind of go quickly because we have a lot of information. The axial views, the facet above the spondylolisthesis, the level of the pedicle, and you can see the large callus here at the level of the pars. One level down. This is the level below the spondylolisthesis, sort of a normalish pedicle. So, any comments? What should we do with this patient? No surgery, epidural steroid injections? Anybody have strong opinions? Surgery? All right, I'm gonna keep going. If you guys want to interrupt me, just stop me. So just for everyone to know, spondylos is Greek. Anytime something's Greek, we have to talk about it because I'm Greek. It just means vertebra or spine. Listhesis, slip. Lysis means to separate. Optosis is falling. And the pars interticularis is the area between the joints. And just as a review, some amazing facts. 5% of all humans have it by the age of 6. Prevalence in adults is somewhere between 6 and 10%. We're the only animal who gets it. If you never walk, you never get pars fractures. Some people, Eskimos, people who speak the Inuit language are like 50% rate of spondylolisthesis, pars fractures. And there are contributory behaviors. So if you look at all the animal kingdom, this is a raccoon. The lumbar spine is mostly kyphotic. And this is a cartoon of, on the left, before I started residency at Union Memorial, on the right when I finished. And you can see I got a lot of lordosis in the lumbar spine, right? Like almost all the lordosis in the lumbar spine. And you look at the compression, where the compression is, this is probably L5. There's a big compressive force at L5 to give us that lordosis so we can stand. And who does this all the time? So these are the behaviors that especially get extension. Wrestlers and football players, female gymnasts, divers. And you can see right there, it's quite obvious how much extension these children and adults get. So the isthmus is, we talked about what's an isthmus, that's the isthmus of PP. And how many isthmus fractures slide? So it's a big question. I don't know if you've been practicing, the parents get so upset when their children have a pars fracture. And it's just 4%, very small minority of the children develop a spondylolisthesis. And this is the way I explain to the patient. It's a bunch of tubes, segmented tubes with a wire in the middle, which is the nerves. And if these slide, they can compress the nerves. And now I have a question. Do you think spondylolisthesis is a source of pain? What does everyone think? Subluxation. I mean, I have a strong opinion. I think it is a source of pain. And just to give, as orthopedic wise, this is a patient I saw on call as a Charcot joint. I think if joints slide and are unstable, they're more likely to be painful. Here's a normal knee, and here's a subluxating knee. And I think this is sort of what's going on at the level of facet and spondylolisthesis in the lumbar spine. And the other thing is pars can elongate. So on the left, it's reduced. On the right, it's not. And this is a case you can see on the CT scan and the MRI that it elongates, it tries to heal, it fractures again, elongates, tries to heal, fractures, heal, elongates. And on the right, you can see that pars is really long, and it's healed. The other thing I want to point is that the sacrum can become round in severe cases. And as part of my fellowship, I had to review sacrums and all the deformities that can occur with spondylolisthesis. And the spondylolisthesis, I think, well, Chuck, who gets spondyloptosis?
Mainly younger. Teenage girls tend to show up with it more than any other group.
Immature. So I think of it as like Blount's disease. You have a deformity at an early age.
Now we have elements of dysplasia here. You see the triangulation, and the sacrum, of course, is completely round. That's the spondyloptosis, where the entirety of the body is L5 below the top of the sacrum.
You draw a line here. L5 is totally below.
That's kind of free fall mode. That will just keep working its way down.
It's usually patients with dysplasia that starts at an earlier age. Remember, the isthmic spondylolisthesis starts at teenage years, but spondyloptosis, I think, is from dysplasia that you've had since you were a kid, and you're born with, and that's why you get the developmental changes by the time we see them. They're
Teenager.
You know, it's 10 years of that abnormal forces versus the 12 or 13-year-old who gets the isthmic spondylolisthesis problem.
So like a 6-year-old child has the pars fracture, and then as the child's
Rare to
growing,
get 6 years old. Usually, if you look at the Frederickson report, they typically occurred in the latter years. Frederickson did that.
Well, the 6-year-old is that there's no case examples of spondylolisthesis earlier than that. So it's a true.
okay, so just the classification for Wiltse: dysplastic, isthmic, degenerative, traumatic, pathologic, iatrogenic. And Leon Wiltse was chief of orthopedics at Walter Reed and practiced mostly in California. And the Marchetti-Bartolozzi classification is a little simpler, just breaks it down: developmental, acquired, if they have spondylolysis, and if the pars is elongated. And another reason is if the sacral hook is deficient. So if the posterior elements are just absent, that's another reason you can develop deformities. So the question is, do you reduce the deformities? And if you reduce the deformity, what can happen to the nerve root? So I thought maybe, Chucky, can you explain this? Does this cartoon make sense? This is from what you told me of the sciatic nerve at the level of spondylolisthesis, reducing it, the sciatic notch, and the nerve goes all the way to the foot.
Yeah. So if this is a sacrum and this is the lumbar spine, as the lumbar spine starts going into kyphosis and translating anteriorly, the origin of, say, the L4 and 5 nerve roots, really 3, 4, and 5, is getting closer and closer to the sciatic notch. And over time, tissues contract. So, to reverse that, if you're going to reduce the spondylol, by definition, you're going to lengthen the nerve roots. And if you lengthen the nerve roots, you encounter the root lengthening limit. So any tissue in the body can be lengthened to a point per hour, after which it ceases to perform normally. That would apply to blood vessels, to nerves, to any conduit type tissue. And so over the 110 spondylolithoses I've done, I've tried to identify the factors which give us a root lengthening limit. And that, as Spiro knows, actually remembers when we briefly talked about this, in most people, a 2 centimeter lengthening is not a problem. There's enough stretch without causing physiologic impairment in that long course of the sciatic nerve to accommodate that. And then as you encounter different conditions, say very stiff, very long-standing cases of severe slippage, and now your limit starts coming down. So actually, I give you the reverse. In the ideal case, you can get up to 6 centimeters of lengthening, which is astounding. Now that is not doing it immediately. If you do this real quickly, you are going to impair particularly L5. And if you want to push it, you can impair L5, L4, and L3. So it's a gradual instrumented reduction to be able to bring people back to a reasonably normal alignment. And if you can't safely do it in one stage, then you can bring them back partway, lock it, and then continue a week later. So that's a quick summary of instrumented reduction. Yes?
After you preoperatively plan for that, is the amount of...
That's the ideal question. He is not a setup.
Look at the slide.
So Spiro will take over.
So this is from Vaccaro's chapter that Chuck and Charles, his son, wrote. Just if you could take a pre-op and then post-op where you want to go, and then measure from the nerve root at the level of the pedicle and the sciatic notch, you can estimate how much you're going to lengthen. And on the top right, these are all the factors that predispose patients to an injury. Older people, apoptosis for a long time, a very large slip angle, fixed lordosis, previous surgery, and if they have a radiculopathy pre-op. So if you have those risk factors, it's less likely that you can tolerate a stretching of the nerve root.
Sure, let me jump in.
Yeah.
The way we really do this, and this is for spondylolisthesis patients, not a grade 2 or 3 slip, but grade 4 spondylolisthesis, I actually take a standing X-ray and an extension X-ray of the patient, and then cut out cut the film at the bottom of L5. So we've got 2 X-rays. So here's the patient's X-ray, and of course the lumbar spine is tilted forward, and then we superimpose the other X-ray, and then if you measure the change in distance from the underside of the L4 pedicle to the sciatic notch, and now here's the other view superimposed, and that's the length. So we've gone from that to that, measure the distance, and that shows you how much lengthening the roots will effectively have if you perform that degree of reduction.
Okay, so these are actually my notes from 2002 when I was at University of Maryland of how to reduce a spondylolisthesis, and I've always done this my whole life. Is when I learn something, I write it down, and this is more of a curiosity because I wanted to show Chuck because it brought back a lot of memories. Just we insert the cob in the facet, just twist it, rotate it, and that can usually break that pars. And then I think the most critical part of this operation is on the right in the middle. Is you develop this massive callus, ossified cartilage, right in the inferior portion of the pedicle, which digs into the nerve root, and you have to decompress that. And the question is, can Megan give any idea why that's especially painful, that part of the nerve root, right there, right under the pedicle, inferior portion of the pedicle? Yeah, that's the dorsal root ganglion. So the dorsal root ganglion is exactly there. It's extremely painful. It's got a lot of nociceptor fibers, and that's why these patients have exquisite pain. And then this is what it should look like when you're done. You see a nerve root right up against the pedicle, right up against the screw, and it should be clean. And that last portion, I usually use a curette to shave it down. So any questions so far? Anybody? Okay, we'll have some more time to discuss things. So just because you reduce it, are you out of the clear? So this is just a case where it's a mild reduction, but I lost the reduction post-op. You can see the top it's reduced, the bottom it's not. So, for me, that's an issue. Anytime I reduce something, I think, can I reduce this? Is the screw going to hold? Does anybody have any rule of thumb for this? Like, what screws will hold and what will not? I mean, my ballpark thought is just an elderly woman who's osteoporotic, low probability the screw is going to hold. Bicortical, I think, more likely to hold than unicortical. How can we measure spondylolisthesis? And different ways to. Yes.
Let me
Go ahead.
comment on that last point. The degree to which a screw will hold is, of course, a function of its diameter. Bigger diameter, the more it's going to hold. Secondly, the difference between the outer and inner diameter of the screw threads, the surface area of bone within the screw, so to speak. Thirdly, the length of the screw. If you incorporate the anterior cortex in a screw thread, that increases pull-out strength 15%. So in doing a spondylo where I'm going to have one level of fixation above, if I am going to do a reduction, and of course if you do a reduction, you know that all the anterior structures of the body, including the muscles, have also contracted. And so when you bring it back, all those tissues are trying to undo what you just did. So in a challenging situation like that, you want a screw with a good bit of difference between the inner and outer diameter. You do want to catch the anterior cortex. I just want to add this.
Absolutely.
Yeah, I think the other point to make too is just the triangulation piece is key. I think Brian, you showed this in the lab, that when you triangulate, when the tip of those screws
Yes.
are more medial than the back, then when you're reducing, you're using all that bone in the middle of the vertebral body, and that helps you in your reduction strength and also reduces pull-out versus a straight-on trajectory where the screws are.
Yeah, that's extremely important.
Okay, so just,
With regard to you were saying the interior structure pulling back, do you find that like a T-lift or A-lift or anterior column support prevents that at all, or are you relying mainly on the screws to that?
Well, it's good you brought that up because the answer would be yes in the case of a low-grade slip. In the case of a high-grade slip, what is the greatest risk for you, the surgeon, and for the patient? And that is going to be nerve root stretch and loss of, say, ankle dorsiflexion. So that's your number one concern. And therefore, you don't want to add to the length any more than you have to. So in a high grade, the answer is no. And the best way to counteract that are two. One, gradual reduction, and secondly, post-operative bracing.
I will cut the top, the other thing you said, cut the top of the sacrum too. That's another option.
Yeah, but when you get to the actual stages of high-grade reduction, you first establish your root lengthening limit, and then you don't exceed that. Well, how can you say that? Well, either you limit the reduction, but that's dangerous, because if you don't get the person in alignment, your rate of failure goes way up. That's true for any spinal surgery. You need to end up in normal anatomic alignment overall. And as Spiro said, step two is shortening the distance. So you're going to take out the disc, and then you start shortening the sacrum to stay within the root lengthening limit. So virtually any spondylolisthesis done in an adult, we are shortening the sacrum, and that's just osteotome on either side of the dural sac, taking it off and pulling it out with large pituitary or curette.
Okay, so I want just a couple more points. MRI, I always evaluate the facet, and if there's fluid within the facet in a normal alignment, I think that, you see there's a lot of like a gap within the facets or fluids within the facets. I feel that in the scanner, the patient's reducing and the patient has a dynamic spondylolisthesis. So personally, I think every patient needs standing lumbar films and flexion extension views to fully evaluate the spine. And then another finding is pedicular edema. I don't know if Dr. Sexton, if you want to like add anything other things, MRI findings. That can also be a subtle finding of spondylolisthesis and a pars fracture.
Right, yeah, I agree. The components are the signal in the pedicle and pars, degree of hypertrophy of the facet joint, degree of listhesis, all those contribute to the pyramidal stenosis. Sure.
Okay. So I'm going to move quickly. I'm sorry, move quickly, but the MRI sometimes for the pars fractures can be subtle, and better imaging is a CAT scan where it's clear that where the fracture is. And a bone scan also, I think, helps sometimes. So this is a case of mine. I'm going to do it quickly. There's a 14-year-old boy who came to me with all of his imaging, and he's a national level soccer player, and his back kept hurting, and mother kept asking for more imaging, and the pars fracture was found on a bone scan, and then they got a CAT scan which showed an L4 pars fracture, and then they came to me, what should we do? And I said, stop playing soccer, and I was like, no, definitely not that. And I was like, well, okay, how about a brace? Because it's hard to play soccer in a brace. Here's the axial cut. This is 2009. So, he tried to play soccer in the brace, but he wasn't that good. So he decided, just to wear the brace, he has to stop playing soccer for 3 months.
Can you go back to the CT 1 second? I think it's important to show that picture. So Megan, can you describe what you see on that CT scan?
This is a lateral, I'm sorry, special view. There's a fracture line within
Can you tell for sure?
I guess you can't, you want to see more views.
Is it possible to get a fracture of the pars that doesn't go through both vortices?
I guess that'd be a stress fracture.
Okay, so a stress fracture does or does not go through both vortices?
Cortices as opposed to sides.
Right, yeah.
I guess it should go through both cortices.
So where does the fracture start then? And in that L4 vertebra, and in the pars area, does it start on the foraminal side, or does it start dorsally where the L3 inferior spinous process comes down and impacts the pars?
I would think that it'd be on the foraminal side, since you'll have tension.
That's right.
And then pressure on dorsal.
So these are a continuum of injuries. So it starts with a stress response on an MRI. You can get a CT scan. You said no fracture at all. And then you can see just a tiny crack on that foraminal side, on the tension side. The dorsal side does not have to be fractured. And then it can propagate all the way through. And then it can be unilateral, and then it can be bilateral. And then you can get what I call pars equivalent injuries, where it's not the pars at all, but you'll see a fracture through the pedicle. Or the pedicle, and then it sort of exits through the pars or into the facet. So, it just depends on where the force lines are going. But I think it's important to understand the mechanism, which is tension side fracture first.
I would add to that, one, to agree, but also to point out that on the more subtle of these, we can walk right past them, even an experienced eye. So if you get a negative report, obviously you're going to look at yourself and get with us if necessary and appropriate to addend or what have you, because I've seen them, you and I have worked together, whether it's be sclerosis or whether it be a couple of millimeters of a break, that can be easily walked over.
Mm-hmm. I saw a patient last week where they had an MRI scan where the radiologist read it as a defect in the L5 pars. And I said, well, look, before we call this a defect, let's get a CT scan. And on the CT scan, there's no fracture at all. It wasn't even a defect with a slip. There was nothing. So it was just some edema in the pars. And what happens on the MRI, the sagittal cut got lateral to the pars, and then they're seeing the SAP of the sacrum. And then there was a gap you see before you see pedicle of L5. So it looked like a defect, but they just were out of plane on the cut.
Okay, so back to our 14-year-old wore the brace, and then I didn't order the CAT scan. Somebody else ordered the CAT scan, but the mother demanded a CAT scan, and you see the fracture's healed. So it's in children, it's possible.
Note that brace had a thigh cuff extension, just so you know. You're not going to mobilize that well with just a lumbar fixed brace.
Yeah, I didn't do the thigh cuff though, but I didn't give the child the thigh cuff, but that is a point. Like to mobilize the lumbar joint, you need a thigh cuff. I just didn't think. I'm kind of flying through everything. It's a good point. So the children can have hamstring tightness, and therapy can sometimes help with the tightness. And there are techniques to repair the pars. Here are 3 different techniques, and a pedicle screw and hook. Do you all have any opinions about repairing pars fractures in no spondylolisthesis, just spondylolisthesis?
I mean, if someone's failed multiple attempts at non-operative treatment and they still want to try to stay active, this is usually kind of elite level athletes, then I think it's reasonable. My favorite technique is a scalp wiring.
The similar to the middle one?
Mm-hmm.
Okay. All right, let's just keep moving. So a fusion is a typical option for these cases. So the other question I want to ask everyone is, does every isthmic pars fracture with radiculopathy need a fusion? And every time anybody asks you, the answer is always no. But I just thought this was an interesting case of a 61-year-old man I saw with right sciatica. He had 2 opinions for L5S1, where they both said fusion. And a friend on the golf course said, go see me because I was nice. And not a lot of spondylolisthesis, not much motion at all. And he obviously had an L5 pars fracture on the top on the CAT scan. The foramen was stenotic. And you can see he has some elongation there and a lot of callus at L5. And I told him, it's a high risk for this not to work, but I'm willing to do it. I think I can do it. And I did you can see my decompression that I performed. And he's 8 years out now, and he feels fine. And I feel like my responsibility sometimes is I'm not sure what the right answer is, but I talk to patients, and he's been fine. I'm kind of surprised how long he's lasted. And he's a golfer, very avid golfer. So fixation options. So this is where Brian's going to talk to us. This is just my simplistic mind. The iliac screw is the strongest screw that I know in the middle of the ilium. There are other options like the S2 screw that goes through the sacroiliac joint. Actually, I want to poll everyone what their thoughts are about this screw. Personally, I don't like this screw because I find the sacroiliac joint is a source of pain. And I feel that I'm introducing a source of pain in patients with the sacroiliac, the screw that goes across the joint. And why just not avoid? I mean, I feel that it's just a little bit more difficult to connect it with the iliac screw. But I don't know what people's opinions are for this screw. I've never done it.
Well, we've done a bunch of them, and I've talked to Cal about it. And I think it's easier to attach than a pure iliac screw because you don't have a cross connector. I mean, it's in line with your S1
Closer
screw.
to the midline.
Yeah, it's deeper. You don't have to worry about the problems. We just recently did an iliac screw, trying a different technique with the robot, and we were able to make it work, but it was more prominent. It didn't seep as close to the sacrum. I have had a couple of patients that I think have had some SI joint pain with it. You talk to Cal, they really haven't had to remove many of these screws because of pain. I think the older the individual, less likely they have motion or functional motion at the SI joint. Perhaps a younger person who has more motion is more likely to get some symptoms or break the screw potentially. But these are really designed for the 70, 80-year-old osteopenic patient that you want to stabilize the pelvis, and they usually don't have much motion in their
There's less motion. There's less motion there.
Yeah, and I think there is a real advantage of hooking it up and having that screw head right in line with your S1 screw.
Yeah, the other advantage is there's far less soft tissue dissection involved, whether it's an adult or a kid. So, I mean, look at that picture. To get your start hole, because you're going in to out, you're basically, to get your S1 pedicle screw in, you've got to expose where you put your SI iliac screw in. And that, to me, is the major issue. Otherwise, you're exposing way out lateral over the ilium. So you're buying some increased pain early on for the iliac bolt, and maybe some less SI joint pain later on, but iliac bolts need to be removed too sometimes, per my hardware. So, I don't know, I like it, but I don't use it in everybody.
I just wanted to bring up the third option for cases that don't require a tremendous amount of hold at the bottom, and that is a S2 screw is used for 90% of the spondylolisthesis.
Check 1 second. 1 second.
Oh, you're going to cover that?
No, right here. Right. Go ahead. Keep going.
But actually, if you back up, I think they go the other way.
Back to that anatomical shape.
This one.
One more.
Okay.
Yeah, that is such a nice cross section of the lower sacrum, and your target is this point right here, so that the screw threads actually wedge into these cortices, and the screw can take from there. Now, in our failure mode biomechanical studies, that does pretty well. It is technically very precise because you do need to wedge it into that corner, but you're not crossing the inside joint.
Good point.
Okay, so just the sacrum, I think, the straight sacral screw, the sacrum is a big metaphysis, and the base can loosen sometimes. And the other point I want to make is the sacrum can fracture. I mean, I've had that happen to a post-op patient of mine below your implants. You can lose fixation of your pedicle screw. So you can do an S1 screw that's pointed medial. You can do a lateral S1 screw. You can do a lateral S2 screw, which Dr. Edwards just showed. And here's just a depiction. And you have to be careful not to catch the five root. You see the five root there in the front of the ala. And the other option is, unfortunately, you can't see the right part, but there's a screw through the sacrum and L5. You see the third one down is an option. So this is just, I know this is simple, but this is how my mind works. So this guy's trying to pull that back, right?
I like it.
And the S1 screw is his feet. They're not that stable. If you thought this guy was on a cliff, it's not, I don't know, it may not work. Maybe, should he have two ropes here? Should he have like a little screw, like at S1? Should he have a really strong point, say in the ilium? Should he have three ropes here? So then, just think about now in spine. Should we just do this, put an interbody, and then how many points do we need in this case? Here are all the different options that were going through my mind, and I had no idea what to do in this case. And I asked everybody, and everybody had a different opinion. I was like, you know what, I'm going to show this on Spine Conference because everyone's so opinionated. So now we have Brian to talk about fixation.
There's some great drawings, Spiro. I like those. You can have this published somewhere. So Spiro asked me to speak a little bit towards the biomechanical considerations in spondylolisthesis. And I wanted to step back first and talk. This is a classic line chart demonstrating the segmental ranges of motion from White Punjabi's classic textbook. And I think this is overlooked in a lot of discussions, but really offers the concept of transition zones. When you think about spondies, and you think about the lumbosacral junction and the formidable biomechanical challenges of that location, this really demonstrates that in terms of the range of motion. And I'll even talk about the occipital cervical region, where you start with a very high range of motion. You get into the cervicothoracic region and it drops down. So it's challenging there. As you know, you get a lot of degenerative changes. Likewise at the lower thoracic, higher lumbar. And what's not shown here is the motion that's occurring at the SI joints. Yeah. So if I were to actually put a line down here and show you what's going on at the sacroiliac joint, this is only about 2 degrees of motion. So as you're moving from L5, S1, and 4-5 usually has a little bit more motion, but here in Punjabis it's a little higher at 5-1. But it's only about 2 degrees of motion here, flexion extension on average. So this is, as you can imagine, from a biomechanical standpoint, at least in this sagittal plane of motion, which we've been talking about, it's a very challenging environment to obtain a successful spinal arthrodesis and instrument. And I'm going to go through a couple of different studies that we've done, as well as some others, just to comment on that. One of the things I haven't heard at Spine Conference so much is about the three-joint complex, and really the synergistic relationship between the facets and the disc, and how this is influenced, not only kinematically in normal conditions, but also in spondylolisthesis. And I think it's important to know, and it's been touched on a few times here, but I'm going to bring it up again, is the amount of load that's transferred between the anterior middle columns versus the posterior column. So in the normal condition, you typically see around 15 to 20% transferred through the posterior column, and everyone, of course, knows what that is, being posterior to the middle osteoligamentous column right here. And then the remaining of that load, 80 to 85%, transferred through the anterior and middle columns. When the facets become degenerated, however, you can see that this load can change quite a bit. Non-degenerated facets, 20%. A lot of work here by Yang and King and others have shown this to go up as high as 47%. So as everything starts to compress, we're getting a lot more loading posteriorly on those facets, less up front. So it's more of a 50-50 split. And this could be affected by posture, and in particular spondylos, when we're seeing that fall off of the dome and higher grade spondylolisthesis, where we're getting unloading of the facets, or an anterior-posterior shear translation, which is really important to talk about. Here it is again. And this is really about the facets, but I want to focus on AP shear because that's one of the things that's, I think from a biomechanical standpoint, is the major loading component that contributes to the fractures and to the instability as presented. In axial rotation, the facets act as a positive stop. They typically can be at 5-1 and 4-5, you can get about 2 to 3 degrees of motion. In rotation, the facets act as a stop. And the disc, if you were to resect those, you could actually torque it up to about 22 degrees, okay? So the facets pick up about 1/3 of the load, the disc the other 2/3. But if you have sustained loading of that, of AP shear, the facets over time, as Dr. Sorry, I'm thinking of something else. Edwards, yes, sorry, I'm thinking about Dr. Miller as well, showed you can get 100% of the loading on the facets. So you really can get that viscoelastic response of 100% on the facets and very little on the disc. In flexion, extension, and lateral bending, I think the facets have the least amount of influence as it relates to the 3JC. Okay. We did hear a little bit about translation, and I think it's important to recognize the center of intervertebral rotation as we go from flexion into extension and lateral bending, right and left. Typically, the center rotation and flexion. So does everyone know what the center rotation is and how it's defined from one segment to the next? Basically, so that's the point of rotation about which this body is rotating relative to the body below. So in flexion, this particular point is anterior. It's localized here in the anterior column, and it moves into extension. And that's really important to recognize because that indicates it's not a fixed center rotation. There's a component of translation that Spiro talked about, and subluxation and motion possibly causing pain. In this loci of motion, which was defined by Stan Gertzman early on, way back in '84, is very localized here. If you looked at it combined, it's usually located right about here in flexion and extension. And then, of course, left and right lateral bending is to the right and to the left, and the locus tends to be in the center. But here's the real important thing. When we're thinking about degeneration, this can be a degenerative change, an isthmic where we're getting healing and the callus formation. This locus of motion can become much more diffuse. This center rotation can actually be localized way out in front of the body, particularly in that obese and very high BMI patient that we were talking about, where the axis of load, we'll talk about the sagittal balance in a second, but can be located out anteriorly as well as posteriorly. Here's where it's normally located here. So just be conscious of the fact that the segmental motions are A, they're coupled, and B, when they're degenerated, there is degeneration, there's a higher element of diffuse locus of motion occurring as a motion segment. So what are the challenges? Well, kinematically, we have increase in spondies, and there are different, of course, different types of spondies, but as you read through the literature, actually the ISLS Prize in Biomechanical Engineering recently was demonstrating increased, this is in patients, 14 patients by Dabrowski and colleagues, increased flexion extension motion, as well as increased AP shear translation, which we just spoke about. So formidable challenges in terms of the kinematic properties, as well as the center of intervertebral rotation, and this is influenced, I think, by degeneration of the three-joint complex. And this significantly affects the spinal pelvic sagittal balance and stability, what we've heard Dr. A number of people talking about Dr. Sponseller as well. So this slide, unfortunately, this is in the way, but I wanted to bring this up because you can see a little bit of the SVA line being anterior here, and we want to shift this back to achieve the sagittal balance. I think Dr. Durian did speak about the 3 S's of balance: sagittal balance, stability, and stenosis, and here we see 2 of those. So what are the studies on these? And these aren't cherry-picked, unfortunately. I asked Nick to just go through and pick up some articles on spondylolisthesis biomechanics, and this is some of the work that we've done in the past. I had a chance to work with Keith Bridwell on this. Is there any way to remove that box from the slide here? Unfortunately, well, you can kind of get the idea from the left slide. And what I wanted to show here is just that this is a porcine model, not a human model.
There are actually 7 lumbar vertebrae here. So this just looks at what happens when you have S1 screws in at the lumbosacral junction. And this is the overall effect of motion, normalized to the impact condition. So the take-home message here being that in our hands, when we were doing these reconstructions, we didn't see a significant benefit by adding an interbody cage in terms of the overall flexibility of the segment. We did, however, see a reduction when we added iliac screws, and in particular, iliac screws in a cage. And I would caution you, whenever you see a word, a title that has the words biomechanics as well as spondylolisthesis, I would caution you that really we cannot represent and duplicate a spondylolisthesis model in the lab. It's very challenging. It's more of an injury type pars defect where we may cut PLL, cut the posterior or the middle osteoligamous column, but we're not getting the biologic response of healing and the slip. And oftentimes we'll get 2 halves of an orange at the end of the day. So it's challenging. So be conscious of that when you read articles that talk about this, and I'm to blame because I oftentimes put those 2 words in the title of different papers. But technically, it's not a spondylolisthesis. It's a pars defect posteriorly, and you're trying to actually create a little bit, even manually, or by anchoring the specimen at a different angle, say a 45-degree angle, and pressing down on it. So the next question is what happens with S1 at the S1 screw level? And we saw a lot of different hand drawings here on where to put the S1 screw. Should it go up? Should it go down? Medial triangulation is very important in getting that trapezoidal mass of bone necessary for pull-out. But what happens if you just have pedicle screws alone versus a femoral allograft at 5'1" versus iliac screws in terms of S1 screw strain? This is a study I did with Keith Bridwell, and what we did is we actually instrumented in a systematic fashion, starting at 5 and going all the way up to L1, looking at what happens at the S1 screw strain when you have pedicle screws alone. And you can appreciate once you get to about 3 and 2, and particularly 1, there's a very significant increase in the strain on the S1 screw by itself in the absence of structural anterior column support. When you add a femoral allograft at 5'1", you can appreciate it does come down, but it doesn't offer the biomechanical advantages of iliac screws. But that, of course, you have the issue of crossing the SI joint, not necessarily directly, be it if it's a PSIS orientation or an ALAR technique, but from a biomechanical standpoint, this is your most stable construct if you want to avoid having that further dissection to the PSIS or the complications of going across the SI joint, such as an ALAR technique. You can advocate for an interbody structural graft at 5'1".
I think that's an important slide for the residents because it's important to realize that the reason for additional fixation is protection of your S1 screw. It seems obvious when you look at this, but that is the main reason to do it. You're protecting your S1, and you can see there how it completely levels out. That darkest black line, it just completely levels out. I think of it as neutralizing the forces on the S1 screw. And that's going to be the greatest form of failure with these constructs.
That's a good point. And the same likewise, this is just flexion. So we separated it out. This is very interesting because we actually strain gauged. This isn't high enough. But we actually had strain gauges down inside the S1 screw on the anatomic right. And here you are at an extension again, looking at this. And trends are very similar, but iliac screws offer the greatest stability at the lumbosacral junction, whereas pedicle screws alone, in the absence of anterior structural interbody support at 5'1", being more or less middle of the road.
Just one quick point. The other thing that you haven't mentioned, which is important, I think, no question you're protecting the S1 when you put in an interbody, but the question is, are you protecting the sacrum? And at that point, is there so much stress on the sacral fixation that you run the risk of a sacrum sufficiently fracture? And that's why I know that from talking to Cal, anytime they go over L3 to S1 and above, putting a unilateral sacral screw in because of the chance of getting a insufficiently fracture of the sacrum.
Unilateral S1 screw.
And that's what we've started doing with multiple levels, just not just protect the S1 screws, but to protect the sacrum itself, especially in an orthopedic patient.
Mm-hmm.
So
think of that as the pelvic fixation is like a neutralization plate on an ankle, right? You know, the 1/3 tubular plate. It's the same exact concept. You put your lag screw, which is your fixation, and the neutralization plate is that 1/3 tubular plate.
Good point. Here's some work by Ted Chomo out of Missouri. I think this was very interesting. This is a study he was just looking at 5-1 and a calf spine model. And he was not only doing he was creating the spondy, but again, he didn't incorporate the biological response of the spondy. It was really a fracture model and looking at anterior plates. We really haven't talked about that. I didn't see any drawings of an anterior plate on your napkin sketches. But there are some implants out there now that actually are designed to offer reduction of spondies where you can go in from the front and actually push back. I don't know. Are you using any of those? Have you tried any of those? What do you think about that? Just out of curiosity.
I haven't been that happy with them.
Okay, I'm curious.
I don't think they neutralize the forces nearly as well. I think the posterior fixation does a much better job at handling all that anterior stress.
Yeah, agreed. I haven't been a big fan of those, and I've always wondered about these. But these essentially, for you that don't know, you can actually reduce as we were talking about quite a bit here, but you can push from the front as opposed to going from the back. But you're relying on integral screw fixation, much like for an ACDF or something like that. I simply don't think you have the screw purchase necessary to do that, and might be setting yourself up. But, it's just it's a new sexy implant, and there's some implant companies out there trying to push it, and just be cautious of that. But this offered a study comparing a screw that actually compressed versus didn't compress from the front. It wasn't a plate up front as opposed to a zero profile. He then did a comparison of pedicle screws with a clip, and then he did 360. So he had plate up front with interbody structural support plus pedicle screws on the back. So he obviously had a front back operation, and here you go. The best, but I think you can get away with obviating that anterior approach and instrumentation and just rely on posterior fixation. But this is a nice study, and a lot of credit to Chomo for this. And the last thing I wanted to talk about, and really we touched on it earlier, is that of alar fixation. Justin and I are just publishing now, it's coming out this month, the study. It's looking at, with Paul Sponseller, looking at alar fixation. Sorry, I can't see this. Is one of Paul Sponseller's x-rays from a patient. Not a spondy patient, but I wanted to show you some of the challenges of placing those alar screws compared to the PSIS technique. You really have, for those of you who haven't done it, of course, I've only done it in the laboratory, but you really have to lower your hand to get those things. It almost seems like your hand is parallel to the floor when you're inserting those screws to get them across. But Justin's comments and to Paul's comments as well, you have the advantages of rods that are in line, so you can capture that S1 screw as well as the prominence of your instrumentation. And kinematically, and this is my last slide, I just wanted to bring to light that the fact that if you are just going to instrument to the sacrum and not include the iliac wings, you're setting yourself up for a lot more or greater increases in SI joint motion. Okay, so you can see this here in flexion extension. You can appreciate this is with S1 and S2 screws versus alar, be it unilateral or bilateral fixation. There's a lot more SI joint motion here in flexion extension. Fatigue, forget about that. We did it 40,000 cycles, it was about the same. And likewise here in axial rotation, you can really get an appreciation for the increase in SIJ motion, just instrumenting to the sacrum and not including the iliac wings. Okay, so those are my thoughts on it. I certainly answer some questions as we go through.
So we're running out of time, so we'll just go quickly. Just in case can't see anything. Just do your best. Slowly put in the screws. AP view. And then at the end of the case,
I'm going to take away this board over here.
to be able to see. Here. And just the post-op CAT scan, iliac screws. I went up to L4 and used iliac screws. So that's it. So any questions at all? All right, thanks everyone for coming.
Very good.
Thank you.